Thank you, Artie, for the kind introduction and for the possibility to be here with you during the next 15 minutes, because I just actually wanted to show you a case which I treated, and Kevin also filmed the part of the treatment. And I just wanted to go over several steps which we will highlight. Just briefly, this was the initial situation. It was a steep bite, deep bite, class 2. So we did some small ortho first. This was then the situation after orthodontics. It's still kind of a tendency to a steep bite, so we wanted to change that. We wanted to change that restoratively. So therefore, we decided to intervene restoratively. There were done a lot of composite restorations in these teeth, and the patient would like to change them for ceramics. Although a lot of the restorations were on the palatal and on the labial surface of the teeth, they were not fully restored. So we decided to look for a way where we could try to do it as minimal invasive as possible. Well, when we first started, as you all know, we start with a DSD at first. So that's what we did. And with the DSD, we created a wax up. So the first step of it was to create a wax up. This was done in an analog way, like the old-fashioned way. But the wax up, we used it to transfer the wax up to the intraoral setting. So here you can see the upper jaw perfectly waxed up. Also trying to change, as you can see here, trying to change the inclination of the central incisors and trying to improve not only the aesthetics, but also trying to improve function, because that's of a major importance. Here you can see the mock-up in place. And with the mock-up in place, we use the Physalis temp here to try and visualize the new aesthetic situation that we wanted to achieve. We also tested the functional aspects here. So we try with a mock-up, we let the patient go in for about 4, maybe sometimes 6 weeks with the mock-up in place. So the patient can actually really have a try-in period with these temporaries. So after the initial plan or the mock-up was approved by the patient, we decided to go into the next phase. So when everything is going well, functionally, aesthetically, only then we proceed with the procedure. And up till now, up till this part, we didn't do anything yet. So we did not really intervene with the burr. We only added material, we changed the shape of the teeth, but we did not use the burr up till now. So if the patient does not agree, does not apply, does not want to continue with the treatment, nothing is wrong or whatever. We can just remove the mock-up and we're back to our initial starting position. So here we can see it from a little bit closer from the intraoral aspect. Of course, you can see these are temporary materials, but it still looks like very attractive, and the patient can really see from color-wise, shape-wise, and function-wise how her new teeth will perform and how the new teeth will actually function. Also from the side, here you can clearly see this is a different inclination of the central incisors. As you now look, we also addressed the palatal part. Therefore, we changed function and we changed the steep guidance, because initially there was a pretty steep guidance and a deep bite. Of course, we were not able to address the deep bite completely, but we could improve it in a major way. So here you can see it from the side again. And as you can see, color-wise and integration, although we did not apply the temporary material everywhere, you can still, this looks quite acceptable to test drive for several weeks. And here just a singular close-up from the anteriors. Then when we look to the occlusal part, you can see here now the occlusals. We changed the occlusal scheme in order to get better function. Now, after approval by the patient, we started preparing the teeth, and I decided to go here with a minimal invasive preparation, which is called the sandwich technique. So I prepared palatal backings and I prepared facial veneers. So first of all, we decide to use the grooves, depth grooves. Although on the palatal side, it's a little bit more difficult to create those depth grooves that you normally see on the facial. So we decided to go here with those palatal backings by lithium disilicate, but we still wanted to have enough thickness. So in order to be able to prep through the mock-up, I used just a round burr of approximately the thickness that I wanted to keep for my lithium disilicate, and then we started to prepare the palatal part. This is after preparation, removing the old composites, preparing the teeth, and then applying retraction cord and taking the impression, and so on and so forth. When the patient was having temporaries on the palatal side of the anteriors, I decided to build up the posteriors by hand. So I used direct composite, which I transferred from the wax up to the shape of the teeth. First of all, we removed the old composites, and then we build it up with composite freehand. So this is not in the original occlusal scheme, but this is in a new elevated vertical dimension of occlusion. Then after changing the posteriors, the molars, we got the palatal shells back from the dental technician. Remember, this is lithium disilicate, it's monolithic lithium disilicate due to strength, and we decided to cement them in one by one. Or I have to say in pairs. I prefer to do the two centrals at once, and then the lateral and the canine. So this is after cementation. And immediately after cementation, this is how it looked. I decided then to continue with a buccal preparation for veneers. So here you can actually see not much changed. We changed the occlusal scheme on the palatal side of the anteriors, but we did not change the aesthetics yet. So what did I do? I entered again the mock-up. So we applied the mock-up again, and we used then the traditional depth grooves in order to reduce the amount of material needed for the space for our restorative materials. So in order to obtain enough space for the lithium disilicate. And this is then after prepping the anteriors. You can see I prepped from 5 to 5, so the 10 anteriors were prepared. And also old composites were addressed. Now this way I was able to keep the positioning of how you position the restorations, both 100% from the lingual and 100% from the buccal. So this is then after preparation. You can see we tend to pay a lot of attention for the soft tissue because this is immediately after preparation, and I tend not to damage the soft tissue with a burr in order to keep it as clean and neat as possible. So then after preparation, we applied the retraction cord. I like to use a double cord technique, of which I place 2 cords. 1 cord I remove before taking the impression, and the second cord then comes with the impression sometimes if we are lucky. And here you can see we have a very nice and clear impression using the double cord technique. So then the temporaries, I will show you in the video later on how I exactly create the temporaries, because here I use a 2-stage technique in which I use the silicon matrix in order to create the coronal part of the temporaries, and I use a flowable to create the cervical part of the temporaries. So let's have a look on the video, and let's have a look what I do exactly to get my analog impression. So I use an impression technique which creates an individualized tray with the Panasil putty. Then I take the mock-up again. With the Visalis stamp, I do the depth cuts. I mark the depth cuts in order to see how much material I still need to remove. Because if there is pencil left, that means that I need to reduce the thickness there. So therefore I'm using it. As you can see, I work under a microscope, and I use the drills here in order just to set the margin. Remember, we have the initial entry of the restoration in this part could be completely from the buccal part. So we do not mind, we can position the veneer from buccally. So then the finishing, I start normally with a normal diamond, then we finish up with a red diamond, and then after preparation we put in our retraction cord. First it's a 0, or sorry, a 000. And this is the green retraction cord, and I place them one by one. So each tooth has an individualized retraction cord. Then we get to a full length retraction cord, which goes continuously to all the different teeth. Now you can see I'm applying the impression paste, but I'm in the same time I'm removing my retraction cord just in time, so I can immediately catch the sulcus. I can immediately catch the impression. So then after that we also take a bite impression, of course, And then it's time for my temporaries. Here you can see I cutted the silicone index just halfway, just at the contact areas. So I only created my incisal part. The rest I will do it with flowable. Why do I do that? That is in order to make sure that I will not catch the papilla inside of the temporary material. Therefore, I'm using the Visalis flow just to create a nice adaptation. So this is the delivery of the temporaries. Then we get the cementation of the veneers. So it's about 4 weeks later that we have the veneers. And I needed to add with fluoric acid the palatal part of my lithium disilicate. Because remember, palatal is lithium disilicate monolithic and the buccal is feldspatic veneers. Here I'm using just floss to check, and I place them two in sets of two, so two the centrals and then the premolars, where we use the Visalis material. Then after placing the restorations, we need to do some minor adjustment. We finish, we polish, and then finally this is how we end the case. This is a 2-year follow-up. This is how we end. I think, no, sorry, this is immediately after treatment. And I need to look at, yes, this is immediately after treatment. And here you can see the combination. So the palatal part is monolithic lithium disilicate and a buccal part with feldspatic veneers. And this is the final smile. Probably this is, I think, yes, this is 2 years follow-up, where you can see the soft tissue is even more integrating with the restorations. So this is from the buccal point of view. And this is where, if you really are working with high magnification and precision, you see a beautiful adaptation of the soft tissue. And this is then from the occlusal part, as you can see, and just one more close-up. So I want to wrap up with this with a final smile, because actually this is probably where we do it for, where we do our hard work for, in order to have those nice results and big smiles of our patients. So thank you for your kind attention.
Welcome everybody, especially digitally, but also here on the Kettenbach stand. Thank you guys for inviting me to give a small tip, a small lecture about how we can use analog things in a digital workflow, because that's basically the topic of today. So the topic is centric in the digital age, and when it comes to things such as centric relation and centric in general and occlusion, a lot of people have a hard time understanding what it exactly is. So it's my job in the next 15 minutes to take you on a little journey, and why I think it is really mandatory and super interesting to have a little bit of knowledge in this whole centric occlusion thing. So who am I? I'm Jasper. I'm a prosthodontist from the Netherlands. I'm a prosthodontist by the NVT and EPA, and I have my own clinic in Oosterwijk, which is in the south of Holland. And we mainly do referral dentistry. I would say 90% of the work we do is referral dentistry. And one of my educational platforms is called Kaige Dentistry, which is kind of big platform. We are active in 144 countries. We are educated over 8,000 dentists, and we have a really cool group of ambassadors. And together we try to basically make dentistry fun again, and sexy again. So when it comes to making kinetology sexy, this is usually how we think about kinetology. We find it kind of boring, and I mean, when I was in the university and people were telling me about kinetology, I didn't find it was really sexy at all. Right? So in my opinion, kinetology is sexy and everybody should know about it, and every GP should at least have a little bit of knowledge about kinetology in the first place. So when it comes to centric, a lot of people have a hard time understanding what it really is. While centric and central occlusion it's not that hard to understand. It starts with understanding that everything that we do in dentistry, we should envision this from a holistic point of view, right? So it's not always about only looking to teeth. I'm a little dead on that myself. I have a few microscopes, I have these big loops, and I tend to deep dive into dentistry and into teeth themselves. But sometimes we forget that everything that we are doing in dentistry, it's just a part of the bigger system, right? It's a smaller part of the bigger system. So understanding how the upper jaw and the lower jaw are combined together and how they move together is kind of interesting. And one of the articles that I find really interesting is this one. It's an article by Charles Green. And Charles is really good in explaining what is centric, why is centric so important, right? But it starts always with a definition of what is centric and central occlusion in the first place. Well, in time, there have been numerous explanations about centric and centric relation and centric occlusion. But the most modern one is it's not that hard, right? Usually, the way I was taught about centric and central occlusion is that we would push the jaw up and backwards, right? But if we do that, then we are positioning the jaw in a way that is not really a good position for the lower jaw and the upper jaw, right? So what I think is interesting is the modern way we look at centric right now is like upper and to the front. And the reason why is because it makes a rotational movement. And this rotational movement is the starting point of how the jaw opens and closes. So when are we working in centric, it's really easy to understand. It's about, every time we have to work in centric, it's about occlusal reorganization, which basically is in the types of our full rehabilitation, full prosthesis, and orthodontics. While if we do orthodontics, and especially digital aligner orthodontics, not that many people work in centric, and it's a mistake because there's no reference when we are moving teeth through the bony housing, and we should find reference points where we can go back to and where we start with our treatment plans. So understanding the whole human skull and the way the upper jaw and the lower jaw move together is interesting. And there's this little figure which I found really interesting in university, but also kind of boring when I was in university because I didn't really understand what it was. So again, we try to make gnatology sexy again, but it starts with understanding how the upper jaw and the lower jaw are actually moving together, right? So if we take a look to this figure, also envelope of motion figure, then we see that you see all these little points, you see all the little explanations, and these three are the most important ones, right? There's ICP, it's what we taught ourselves in how we should close the upper and the lower jaw. Then there's RCP, which is the retruded contact position, which is like the centric occlusion. It's when the lower jaw actually closes to the upper jaw. That's the first point that we make contact. And then there's centric. And a lot of people think centric is a certain point, while centric is just a little movement of the upper and the lower jaw in rotation, right? So I guess the most people define centric and using centric in this type of cases. It's a difficult type of case, right? Full rehabilitation, this is how we start. It's difficult because we see the upper and the lower jaw, they're not positioned right together. Eventually we see like a few differences in midlines. So this guy went into orthodontic surgery in ortho. And it was a 2.5 year period. He went to the orthodontic surgeon, he went to the orthodontist, and then he came back to the clinic. And the question was, please make it restoratively, finalize everything restoratively. And this is my starting point now. So why is this important? Because the question is, please finish this case with restorative, while the whole starting point still is not really right. Right? If you take a look at while the midline is shifted, still is shifted. It's even worse after the orthodontic surgery than before. And if you take to the left and we take a look to the right, we still see this midline shift is really crazy. And it's hard to make something from a restorative point of view, right? So we have to do something here. And the first step we take is find centric. And the reason why is because in finding centric, we can compensate restoratively in what we should have done orthodontically and orthodontic surgery. So eventually we finalize everything. But the most important part is this one, right? This is the occlusion. And here we see how this person bites in his maximum occlusion and what his position is in centric, which are two very different positions. But this is kind of complicated dentistry, and it's not for the everyday dentist. While I believe centric and the understanding of centric should be for the everyday dentist, right? So take a look at this guy. This is like the person that we see quite a lot in the clinic. You see it to his muscles. This is somebody that really clenches his jaws together. And if we take a look on how the teeth are actually eroded and are grinded off, right, this is stuff that we see every day. We see the lowers are grinded off. We see that from the palatal side, we see that there's a lot of stuff grinded off. And the big question is, okay, how can we actually remake this? How can we restore this? And it's difficult because our starting position is not right, right? The reason why this is all happening is because the lower jaw and the upper jaw are actually not fitting together. So then we speak about a restricted or a constricted envelope of function. But if we want to restore this, we first have to define the centric and the rotational movement of the upper and the lower jaw before we even do something. And this is somebody who has like exactly the same problem, right? You're literally seeing this person clenching the upper and the lower jaw together with no space at all. And this person is in a lot of pain, back pain, neck pain, headaches, everything. And what happened is that this person did ortho, but only in the upper jaw. So what happened is the upper jaw was actually constricted. So the lower jaw had no room to fit into it. So what is the solution? It's actually also pretty easy. We define centric, and then we just retrude the lowers a little bit to make space for the lower jaw to move in the upper jaw, right? And again, this is all pretty much everyday dentistry because this kind of problems are, we face this as general practitioners. And if we take a look on the other, I guess, really important thing about centric and posture, but take a look to this picture. You see on the left, you see somebody standing up straight, and to the right, you see somebody with a leaf gauge, which is a little device where we can guide the lower jaw and the upper jaw. So now I suppose these two pictures together and take a look on the difference in the posture. So in our clinic, we do quite a lot of top athletes and Olympic sporters. And there's research that sometimes if you adjust occlusion and you make sure the lower jaw is fitting the upper jaw correctly in centric, so all the muscles have the right dimensions and the right length, there's some people and some sporters are actually performing to 20% better, which I find mind-blowing. And on the other hand, it's pretty logical at all when you take a look to this picture, because this person is literally going to stand straight when the lower jaw is positioned correctly to the upper jaw, right? And this, again, this is everyday dentistry. So this was the full rehab that I just showed you. But again, let's go back to ortho. Because when you take a look around here in the IDS, there's a lot of aligner providers. And a lot of aligner providers are starting from maximum occlusion, right? But you tell me, which starting point should I use? Because to the left, you see the maximum occlusion. And to the right, you see the centric. And if we are going to change everything, so if you're going to do a full occlusal rehabilitation, a reorganization, there should be some point we start to work in, and maximum occlusion is not the one, right? So I guess I'm a firm believer we should do all the ortho from a centric position, because that's a position that we always can go back to. So understanding this upper and this lower jaw movement and the relationship between the two of them is super important, and it's quite interesting to have this knowledge as a GP. So communication-wise, this was for a long time what we did, right? We made wax-up models, we had the Stonecast models in the articulator, and we did everything with the analog workflow. So this is how we did, and we started to find centric in analog time. So we just had like the lower jaw positioned with a wax bite to the upper jaw, and then we used the models to put them in the articulator. And there was a lot of room for error in that. But now, as we look around here in the IDS, it's the time of digital dentistry, right? There's a lot of really cool digital dentistry around, and this is how we do it in the clinic right now, right? So we have some sensors, and digitally we are actually recording how the upper and the lower jaw are moving together. And it's not like a somewhere in between or AI movement or whatever. No, this is the actual movement of the patient, right? However, this kind of technology and these devices are pretty, yeah, I guess we're pretty expensive. So it's not for the everyday practitioner. While a scanner nowadays is for the everyday practitioner. And the little tip I wanted to give is how to use a scanner and still record this centric relation from a digital perspective. So it all starts with making scans, right? And I guess I don't have to explain how you make scans. You make a scan from the upper jaw and you make a scan from the lower jaw. And from that point, you start to find centric. And one of the devices that I find really handy is called a leaf gauge. And a leaf gauge is a little piece of paper that you can vary with in thickness. So the thing that you're doing, you're guiding the upper and the lower jaw in the thickness of this little paper. And you're doing this until the moment you find centric occlusion. So it's the first contact that you are having while closing the jaw. And this is exactly where a lot of mistakes are being made with scanning. I mean, a scanner is a pretty big thing, right? So as soon as you want to record this position, a lot of times you take the jaw with you, which actually means that you are moving the lower jaw to the upper jaw. And I don't want any recording with approximately this is the position, or I want the exact position. So one of the things that we then do is we use FUTA to record and to stabilize the bite. And when you're recording centric, this is a handy trick because now you can just scan whatever you want, right? You use FUTA to stabilize the bite, and now you can take the scanner and scan the posteriors so you have an accurate scanning. And it's not that hard, it's super easy. because now you see like the lower jaw and the upper jaw, they are stabilized and you can scan whatever you want. And in those scans, after you scan it, you can analyze. You can do this on your scanner, you can do this on SmileCloud, you can do this in like a lot of different software programs. And you can analyze your models and you can see, so is there something different between maximum occlusion and centric relation? And usually those two don't fit together, right? So is this a problem? Do you always have to go in maximum occlusion centric relation? Should they be the same? And the answer is no, they don't, because a lot of people have different positions in this. As long as it's not pathological, if there's no problems, you can leave it as it is. But as soon as there are any complaints in pain or discomfort, and you don't know where the problem is, it can be really interesting to record centric and to compare this with the maximum occlusion, right? And again, when you're working in any occlusal reorganization, which is a full prosthesis in orthodontics or a full rehabilitation, it is really smart to work in centric and take that as your starting position, because it's a position that you can always go back to. So the main message I wanted to give today is that in all the violence of digital dentistry that we see around here on the IDS and that we use in the clinic, because I would say 98% of the work we do is all fully digital, with milling, with printing, with everything, with AI, with movement. We try to combine it all together. That sometimes you still need some analog things and analog tricks to make your digital dentistry more beneficial. And with that, I want to thank Ardi and the Kettenbach team for giving me the space to tell you a little bit about Centric in the digital age. And I wish you all a great IDS and a great fair. Thank you.
Well, thank you very much. Temporary restorations or provisional restorations are difficult. I think we all struggle with them. If they are in the posterior area, they are difficult. How do we make sure that they stay on, that they're not too tight, but especially in the anterior region? Because we want to give some aesthetics to our patient, but we also want to make sure that we can get the temporary restoration out and that it doesn't stick too much. So that's a topic that I want to cover today, and I'm going over different scenarios that we have for our provisional or temporary restorations. First of all, let's go over the function of a provisional restoration. First of all, it's mainly for aesthetics, because the patient wants to go home looking nice. They don't want to go home with their prep teeth. Also, in order to have good function, especially when we need to redo full crowns. We want to avoid any migration in the period of our impression taking and the delivery of the final restorations. And in some cases, we want to guide the soft tissue. Temporary restorations are never for sensitivity, because if we use medial dentin sealing, we cover the freshly prepped dentin and people will almost never complain about sensitivity. So, for example, let's take this case. This patient had some old crowns that were there and that we had to remove, we had to redo them. And in this case, my provisional restoration is for the aesthetics, for the function, and to avoid any migration. In a different case, where we, for example, do a clinical crown lengthening, we can also use the temporary restoration to guide or support any of the soft tissues. Well, there are different kinds of preparations that we have in the anterior region. We have retentive preparations and we have non-retentive preparations. And we can also divide them in a single tooth preparation, or maybe we have multiple teeth. And for all these scenarios, we need to think of a different way to make our provisional. But first, let's go over the provisional itself. What do we need to make our provisional restoration? Well, first of all, we need a really precise body index. Usually my dental technician makes them on the wax up, as we see here on the top right. But we can also make them in the mouth. So maybe we don't have a wax up, patient comes in. What we can do, we can take a putty, we can make an index, and then we can use some light body impression material to reline our body index to make a really precise copy of the intraoral restoration. Well, then we have our index, but we also need our material. So we need a temporary crown material, for example, Visalis Temp. Sometimes we need a temporary cement, maybe we need some edge and bonding, And sometimes we need a flowable to make sure that we bond it a bit better, or maybe make some small corrections if we have some air bubbles or anything. Well, first I would like to go over the first scenario that we might encounter, which will be the single tooth with a retentive preparation. This is usually the easiest temporary restoration to make. As you can see, we have a full crown that needs to be redone due to aesthetics. This provisional is quite easy. I make a putty index over the initial situation, and if I have the final preparation, I will have enough retention on this tooth. This crown, or this temporary crown, will be 360 degrees around, so I will get enough retention. I can just use a normal temporary cement to lute in the temporary restoration. What's important to remember is that the material has a little bit of a shrinking effect. So if I let it sit on the tooth for too long, it might shrink that much that it's stuck on the tooth. Is that a problem? Sometimes not. We can just leave it, let the patient go home, and let them come back later. What you genuinely want to do is to remove the temporary restoration, because it might have shrunk too much around the tooth that we cannot remove it all at once, and we need to destroy our temporary restoration. So my ideal situation would be to let the material set that it isn't deforming anymore, but I can just take it off. And then during the final setting, I will take it off, put it on for several times, just to make sure that it's completely set, but still I'm able to take it off. Then I can also trim the restoration. So we see on the left, we see the preparation, we see the provisional restoration. I can trim it out of the mouth, and then I can lute it in with some temporary cement if needed. And sometimes it has enough retention already that we don't need any temporary cement. So these are more of the easy cases that we do. But what if we have a non-retentive preparation? Because those are the difficult situations, because those are those temporary restorations where your patient calls 1 hour after treatment. Hey doctor, my temporary restoration fell off. And you don't want to put it on too good, because then you need to remove it again and maybe you need to drill it off. So this is one of the hardest provisional restorations that are there to make. We don't have that much retention that we can rely on. And we cannot really use a temporary cement, because usually these veneer preparations are quite thin. So if we use a provisional or temporary cement that has some color in there, we might see it shine through. So what can we do in these cases? Well, like I already said, the material will shrink a little bit while it sets. So we can use that shrinking effect to our benefit. And we can just let it set completely, and it will shrink a little bit around the tooth. And then it will be difficult to remove. So usually I just let it shrink and let it sit on the tooth, and I don't touch it anymore. I remove it at the day of delivery of the final veneer, but then 9 out of 10 times I have to destroy my temporary restorations. In some cases where I need some additional adhesion onto the tooth, I can use a spot point and a spot etch technique. That would mean that I use a little bit of etchant on the tooth. I will let it sit somewhere between 15 to 30 seconds. I will rinse it off, and only that spot will be etched. So we see a little white spot on the tooth. Then I place a tiny drop of bonding, which I will then light cure, also on that spot. And then I will make my provisional restoration and let it shrink and fully set. So I won't remove it off the tooth, because then I don't have any retention anymore. It's important to know that this bonding will be on the tooth, so you need to remove it before you place your final restoration. Because if still a little bit of your provisional restoration is left, you might end up with the problem that it's stuck on a tooth and your provisional won't really fit. Or even when your veneers are really thin, you can even break your veneer. So that's something that we want to avoid at all times. If we take a look at multiple teeth with retentive preparations are quite easy. So for example, the case that we have right here, you see that I have multiple preparations. It's just enough retention. It's quite easy to make the temporary restoration, similar to the single tooth. The only thing that's important is that the axis of all the teeth are different. As you can see right here, there are undercuts from tooth to tooth. So we have different undercuts, which means I cannot put it on and take it off. So I need to let it set completely, because due to the undercuts, I'm unable to take my temporary restorations off. So I will place my putty index, I have my provisional material, and I will let it fully set and remove any excess. And I need to cut them off at the day of delivery. So there's no way to get them off in one piece. I need to use a burr to at least make them as separate crowns, and probably I will have to break them up as well, because due to the shrinking effect and the fact that my preparations are quite parallel, they're just stuck on the tooth. So here we can see the different preparations that we have. This was a full mouth case, so the back teeth are still in the provisional restorations. Now the front teeth are prepped. We can see that there's a difference in the axis of the teeth, and you can see the provisional restorations on the right side. Patient goes home like this, but when they come back in to place the final temporaries or for the final restorations, I need to cut my temporaries off. So that's important to know. And then the final scenario is multiple teeth with non-retentive preparations. These are quite difficult. We don't have that much retention, and we cannot really use any temporary cement because we have the arch form. Therefore, we also have a little bit of undercuts, so we cannot take our restorations off. And if we take them off, they will be really thin and flimsy and really hard to put back. So what I would do in these situations is get my putty index and I would fit it up with my provisional material, and I will let it fully set again. So just let it fully set, and hopefully the shrink wrap effect and the fact that there are some undercuts will make sure that my temporary restorations will stay in place. You cannot remove them, so these also need to be destroyed at the day of delivery or when your patient goes to the dental technician for the trying in of your restorations. Sometimes in cases you can also use a little bit of spot edge or spot bond just to get a little bit more retention. And as you see right here, I use a really tiny drop of edge, but in most cases I use a little bit more. I make like 5 different drops on the tooth. As long as I take a photograph of the place where the edge is, I also know the place where I need to remove the bonding that I also use. So you can use this to your benefit to get a little bit more retention and avoid that your patient comes back and says, yeah, sorry, my provisional restorations came off. Because that's always the balance that we're in. We want to make provisional restorations that stay on the teeth the entire treatment, but we don't want them to be too stuck on the teeth. So we want to be able to take them off, but not that the patient comes in the meantime and just fills up your program over and over again because the provisional restorations come off. That's always difficult. Then we have another scenario, which are the provisional restorations to guide any soft tissue. In this case, you can see that there's a patient that has a difference in the shape of his front teeth. We can see that one central incisor is a lot wider than the other central incisor. We can also see that there are different levels of the gums. And in this case, we decided to do a clinical crown lengthening in combination with slicing of the tooth. So on the left photo, we see the initial situation. Then we see where we want the gums to be, do the gingivectomy. Then we slice the tooth that's a little bit too wide, and then I place my mock-up. So I use the index that has been made on the wax-up, and I place it on here to guide me for the clinical crown lengthening. So what I do, I make a flap, and with the provisional restoration in place, I can see where the margin of my new restoration will be, and I can make sure that I have enough space between my margin and the bone. So the clinical crown lengthening is done, the provisionals are now taken off, I can put them in, take them off, just to do my procedure. Then I will place my provisional restorations again. You can see on the left, I used a little bit of flowable on the left slide, on the papilla, just to get a little bit of a better shape. You see that the stitches are there, and then after 2 weeks I see the patient again, the stitches are removed, and you can see that the mock-up still looks okay, but not that well. Then I replaced the mock-up, and then I saw the patient again 4 weeks later. And you can see that we use, in this case, the temporary restorations to guide the soft tissue. So we use the temporary restorations, we use the shape, the position, to make sure that the gums end up where we want them to be. We will let this heal over a period of 3 to 6 months. Then we will take it off, make a new mock-up again to check if all the soft tissues are in the right order, and then we can continue with the definitive restorations. Well, for this lecture for today, I unfortunately only have 15 minutes. And this is a topic that I can go on for like forever. So there's a lot more to talk about. And this topic of provisional restorations is one of the subjects that are covered in the Karma Maarten's course. The Maarten's course is a 2-day indirect course where we talk about all scenarios in the posterior and anterior region regarding porcelain restorations. So if you're interested in learning more about that course, take a look at our website, karmadentistry.com. And for now, I would really like to thank you for your attention. And if you would like to see more of my work, you can scan the QR code, or you can find me on Instagram as The Dental Dutchman. Thank you very much.